Addison's disease is a disease due to the destruction or dysfunction of the adrenal cortex, and this results in a deficiency of cortisol, aldosterone, and also the adrenal androgens. So, like many endocrine disorders, it's more common in women and typically found in adults that are over the age of 60. When we look at the properties of Addison's disease, as we've noted before, it's an adrenal insufficiency disorder where the adrenal cortex is destroyed and dysfunctions. There's then not enough ACTH, and typically it's an autoimmune process and can also result from other things, which we'll talk about in the future, and many times takes years to develop. Addison's disease accounts for about 80% of the cases of chronic primary adrenocortical insufficiency, and it's due to a destruction of the adrenal cortex from an autoimmune type of a problem. So other adrenocortical insufficiency problems could be destruction of the adrenal cortex from tuberculosis, metastatic types of lesions, or surgical removal of the glands for whatever reason. This is a picture of JFK, who actually had Addison's disease. You may notice how he always kind of had a tan. That's a skin discolor hyperpigmentation problem that's noted with patients that have Addison's disease, where they get a bronze discoloration of the skin, especially in crease areas like the palms, the knees, the elbows, gums, mucous membranes, those types of things. It's only seen in about 1 out of every 100,000 people in the U.S. It is more common in in women than it is in men. And like I said, it typically occurs over the age of 60. It's a higher incidence in people who have some sort of history of an autoimmune glandular problem, or for patients that have chronic long-term steroid use. Our nursing situation for Addison's disease is going to include a 60-year-old female patient with a history of rheumatoid arthritis. She's been taking prednisone 60 milligrams a day for about 12 years. Her husband was recently diagnosed with cancer, and due to that recent diagnosis and the stress involved on their family, she's forgotten to take her medication for 2 days. And we mentioned in the last lecture the problems and signs and symptoms that we see of patients that stop taking steroid medications that have been on them for long period of times. When you do her assessment, you notice that she's extremely weak, she's lethargic, she has nausea, she has dizziness, those types of things. And part of that is related to electrolyte changes that she has going on within her body. Decreased aldosterone levels will cause decreased sodium levels and increased potassium levels within the body. So this leads to the risk of dehydration and also low blood pressure. A decrease in glucocorticoids can lead to decreased glucose levels and elevated WBCs. So that would help to explain the above symptoms that are listed there for our patient in our case scenario here. The patient goes to the physician and is admitted with a diagnosis of rule out Addison's disease. And when she asks the nurse to explain it, remember that you would indicate to her to explain that there are many different causes of Addison's disease, and it was most likely related to the recent stressful event that she had of her husband being diagnosed with cancer, and also the fact that she stopped taking her prednisone abruptly after she had been on it for 12 years. The next slide looks at the causes of Addison's disease, and the primary reason that's listed when we look at Addison's disease, the primary cause would be an autoimmune atrophy of the glands. This is what we see in the majority of patients. Probably 80% of all Addison's disease cases are due to this autoimmune atrophy of the glands. Could also be caused from a surgical removal of the adrenal glands, possibly due to cancer. Could be also to multiple trauma if there was kidney damage that also damaged the adrenal glands, that type of a thing. Or another cause could be a secondary cause, such as an infection, or the patient, as in our case scenario, abruptly stopping exogenous adrenocortical hormone therapy, such as steroids. Remember, anytime the steroids have been taken for about 2 to 4 weeks, this is going to suppress function of the adrenal cortex, where the patient will not be producing the adrenal cortex hormones as they should, and it leads to decreased levels. Remember that the adrenal gland will actually start to atrophy, and we talked about this in the last lecture. Other things that should be assessed on this patient is signs and symptoms of cortisol deficiency and also signs and symptoms of aldosterone deficiency. So the patient having low level of cortisols would result in hypoglycemia, vomiting, diarrhea, anorexia. The patient may be anxious, restless, irritable, and confused, and those types of things. The patient will also have impaired gluconeogenesis, so the blood sugars are going to be low, and so that's going to cause all those metabolic problems listed above. Patients that also, because of an adrenal problem, have aldosterone levels that are extremely low will have symptoms of hyponatremia and hyperkalemia. Remember, these two electrolytes tend to work opposite of each other. If one's low, the other one tends to be high. And that will lead to muscle weakness, fatigue, hypotension, dehydration, weight loss. And because of such low levels of sodium on board, these patients will actually crave salt. So these are the patients that actually we encourage them to use a lot of salt with meals and those types of things. Some diagnostic tests to check for Addison's disease would include lab tests that would include levels such as blood sugar, sodium, chloride, potassium, BUN and creatinine to look at kidney function, cortisol levels, ACTH levels, and also an ACTH stimulation test. So remember, we talked about those, the ACTH stimulation test in the last test. So this is a test where dexamethasone is or some sort of synthetic cortisol is given to suppress the production of the ACTH, and then plasma cortisol levels are measured after this is done. So see your textbook, and it gives further details to say what exactly the response is from the body after the ACTH stimulation test. Another test that might be done, the patient may have a CT scan just to see what's going on with the gland. Calls for nursing that would be good for this particular patient's problem would be fluid volume deficit. Remember, these patients are losing a large volume of sodium. So with sodium goes fluid, so that puts less fluid on board in their circulatory system. They're at risk for injury, activity intolerance, coping issues, and ineffective therapeutic regimen management for this particular case scenario. Because we talked about the patient forgot to take her steroid for a few days due to the stress that was going on within the family situation. Nursing responses as far as medications we can use to treat Addison's disease would be to put all of those different types of hormones back into their system that they are missing due to the Addisons. So we can replace the corticosteroids with different forms, for example, cortisone. We can replace the aldosterone or mineral corticoids with a medication called Florinef, replace the sodium that they're losing with dietary supplements of sodium and liberal use of the salt shaker, and cortisone or Cortef would be another example of a way to replace the cortisol that these patients are losing. So also refer please to your textbook where they have a nice table on medication administration for patients with Addison's disease. Just as other endocrine problems could result in a certain type of extreme form of the disease or a crisis, Addison's disease can result in Addison's crisis if not treated properly. So things we would want to monitor with these patients would be to check baseline vital signs and then assess deviations from those, look at daily weights, I&O balance because of the extreme risk for dehydration, increased salt intake due to low sodium levels. Remember we said their potassium levels tend to be high, which can lead to some cardiac abnormalities. And because they are at risk for dehydration, we want to encourage them to have about 3 liters per day on board. Activity guidelines, we're going to, when the patients are coming in initially and being diagnosed, avoid unnecessary activity that could precipitate and put that patient that's in Addison's disease into a crisis situation. So we'll also try to minimize stress. In times of stress, surgery, trauma, infection, illness, those types of things, that patient may need their medication adjusted to compensate for these types of situations. So if that's done, the patients could end up in Addison's crisis. Other education pieces we could give to that patient to avoid going into crisis is to do frequent follow-ups with their physician, including lab draws. Like we talked about earlier, they may need their dosage adjusted in times of stress. They need to know the signs and symptoms of when they are going into crisis, and they need to know what emergency measures to take if they can't take oral medications. For example, if they had a gastroenteritis, flu-type symptoms with vomiting, diarrhea, and that type of a thing. Many of these medications are available in an injectable form. If that would happen, that they could take it home, or if they got so sick that they couldn't tolerate those, they come in an IV form if they needed to be admitted with IV therapy. Signs and symptoms of Addison's crisis. The patient will appear shocky. They'll be very hypotensive. Their blood sugars will be very low. They may develop fever. Dehydration and weakness is common. And due to low fluids and that type of thing on board, they'll have headaches, confusion, seizures, low sodium levels like we talked about earlier, and also high potassium levels. They may also complain of abdominal pain, nausea, vomiting, diarrhea, and this can progress to shock, cardiac arrhythmias, and death if that patient is not treated quickly. So nursing interventions for that patient in crisis, they would be in an ICU setting on a cardiac monitor. We're watching for arrhythmias in these patients. We need to do very frequent vital signs to check for hypovolemic state and for hypovolemic shock. So it's noted sometimes that a blood pressure change of even 20 millimeters and a decrease in the systolic blood pressure can indicate extreme fluid volume deficit in these patients. So because of these fluctuations in low blood pressure, they may need to be treated with vasopressors such as dopamine, which will help to elevate the blood pressure. We can give them IV dextrose to increase the blood sugar levels, and we can give them IV hydrocortisone to replace what's lost in the body, and we can give that by IV form every 6 hours. They're going to have typical lab draws about every few hours just to make sure that their levels of hormones and electrolytes and everything like that are stabilizing. A good NCLEX question for this topic is listed here. The nurse is teaching an adult client who has Addison's disease about drug therapy for the condition. In evaluating the effectiveness of teaching regarding this therapy, the nurse should expect the client to verbalize the need of what? And the correct answer would be lifelong therapy. These clients will need lifelong hormone replacements to put the hormones back on board that they don't have.